Okay, thank you very much for the nice introduction. And I will present now the work done by the team in Ansys, including my team in the CTO office, developing the heart model, but also the LS-DYNA development team based in California, developing the software itself. So the presentation is about heart modeling using LS-DYNA. So heart, as you know, most complex organ in the body, and our starting point was the existing LS-DYNA software capabilities developed by the team in California. And what you see on the screen, it's a synthetic heart, a left heart with all attributes, left ventricle, atrium, aorta, mitral valve, aortic valve. And on this synthetic heart, you could compute the electrophysiology, somewhere the electrical waves in the myocardium. And from this electrical wave, you have the contraction of the fibers in the myocardium, and you have the deformation of the myocardium. And finally, you with a third coupling with computational fluid dynamics, and you see the blood coming from atrium to the ventricle through the mitral valve and going out to the aorta through the aortic valve. So that's the starting point, is existing features in LS-DYNA. But when we want to develop patient-specific simulation for heart disease, it's crucial to first validate, verify, verification with the literature data, with the many publications existing in academia, and secondly, validating with clinical data. And the presentation is about cardiac modeling, and impossible to cover all cardiac features in one presentation of 10 minutes, and we focus mainly on two applications. Heart arrhythmia, and second application is cardiac resynchronization therapy. For the first one, the heart arrhythmia for ventricular tachycardia is based on electrophysiology only, and this application is a coupling between the full model solve from a Poisson equation to detailed electrophysiology cell model defined at each node. So for this second application is you have this heart electromechanical simulation. The first physics involved is electrophysiology, the same as the first application, but after that you have the coupling with the mechanics, and very importantly, the coupling with the zero cardiovascular hemodynamics. And the important thing in heart modeling is to develop several types of application function of the clinical targets you could have. So there is not one model, there are plenty of models. So I focus only on the two first applications today. So first we give some explanation about the normal heart. We say normal heart is the heart of anybody, and somewhere without any major disease. So the normal function, the normal heart in the body. So for this electrical part of this normal heart, you have a lot of complexity because you have fibers of orientation in the myocardium. More importantly, you have the coupling between the organ level and the cell level, and the cell level is where somewhere the potential is activated. Okay, and on top of that, you have the Purkinje network. The Purkinje network is a specific network of bars. Imagine some beams inside the endocardium, where somewhere the current go rapidly from the base to the apex. And so all the combination of that is the normal heart. And a way to measure, a standard way to measure electrical activities is electrocardiogram, when you measure the electrical signal on the torso. So that's the basis of the software, is to simulate all those capabilities, but not for normal patient, but for patient-specific one. And the first pathology we focus on is scar-related ventricular tachycardia. What is about? It's about scar. So somewhere fibrosis in the myocardium after heart attacks, where coronary are blocked, and so there is no blood flow through the artery in the myocardium, and so the tissue is damaged. And so the electrical conductivity of the tissue has not the same value. You have, we say, gray zones where the conductivity is lower than normal. And pathology of ventricular tachycardia could be very, very, very dangerous for the patient, because there is some abnormal electrical stimuli, and somewhere there is some conduction of electrical fields in the myocardium, which is totally abnormal. And finally, there is fibrillation, somewhere the heartbeat is very rapid and could go to sudden cardiac death. So the way to treat that, okay, the way to treat that is to somewhere to locate the ablation zone. Somewhere to burn a part of the myocardium to avoid the arrhythmia. And so for the patient, we go from the planning to after that to the catheter lab, and in the catheter lab we measure the electrical in the patient, and finally the cardiologist decides the ablation zones. And the story is about what? Is about a patient-specific heart. ADAS3D is a company in Barcelona selling software of the same name, and it's medical imaging software. We go from MRI, lead gadolinium enhanced MRI, when it's possible to get the geometry, and more importantly, the fibrosis. From the ADAS3D medical imaging data, we have developed an automated workflow to get the geometry, to get the fibrosis, the conductivity properties, and finally compute the electrical waves you see in the simulation, and more importantly, to do some verification between activation times measured on the patient and computed on using the simulation. So that's the first application about ventricular tachycardia. Second application is cardiac mechanics, is a coupling between electrophysiology and deformation of the myocardium. So there are three physics involved: electrophysiology, tissue mechanics, and fluid dynamics. And the challenge is to couple the three, and the right way to go is to consider electrophysiology by using 0D system you see in the middle of the slide, and somewhere to do a coupling between the mechanical simulation and the fluid represented by the 0D closed loop. And two applications, one for the left ventricle on the top, and one for the two ventricle with the full cardiovascular simulation. In the heart, motions are four phases: the contraction, ejection, and relaxation and filling, and all the four phases are controlled by equation on pressure and volume. And so the first level of verification is a PV loop you see on the screen, somewhere how the pressure of the ventricle change, controlled by the pressure in the vein and pressure in the aorta. And for the two ventricle is the same, so except the curves are a little bit more complex due to the complexity of the arteries in the vein coupled to the two ventricles. That's the level of verification where we are today. And step forward is to manage patient-specific simulation by using full heart models. We have access to doing some statistical shape modeling, to have isotopological meshes in order to extract the variabilities, the anatomical variabilities, the extraction of parameters. And finally, the next steps is my last slide. The next step is a calibration. So the comparison between the simulation we operated using LS-DYNA and the data collected in university hospitals for the two applications. And the data includes the results we would like to get for electrophysiology or for cardiac mechanics. And after that, we will consider real-time application by coupling this LS-DYNA software with our existing reduced order modeling offered by Ansys Twin Builder. Thank you for your attention. I'm ready to answer your question if we have time. Thanks a lot.
So, thank you very much, Michel. Rochette. Merci beaucoup.
Oh, thanks.
There's one question I have. Can you estimate how long does it take from the simulation to the patient when it comes down to a heart?
Perhaps from the patient to the simulation, no?
Mm-hmm.
So
how long does it take?
Does it take? So you have two types of. The answer is in two types. The first type is a human usage of software. And unfortunately, in order to be used in clinics, we need to be more or less real time, less than 1 minute, even in planning, because cardiologists do not have time to wait long. So the biggest challenge is to go from medical image, from DICOM file, MRI data, CT data, to the computational mesh. For the simulation itself, we have tools to transform that in real time, but the most complex is to get the geometry of the patient and material property of the patient. Okay, so today it takes definitively too long. First, it's not finalized, it's not finished, but it takes hours today, and we have to go down to 1 minute or two.